Well, I welcome everybody to the session on discrimination in health and social care. In the next 50 minutes, we'll be listening to three 12-minute talks from speakers that I'm going to briefly introduce now. Our first talk will be from Libby Pfeiffer, who's an associate professor. Sorry, 1 second, apologies. Associate Professor of Anthropology at Rhode Island College, who is presenting with Sara Mendez, a senior at Rhode Island College. Next, we'll hear from Arshdeep Kaur, who's a third-year medical student at California University of Science and Medicine. And then we will listen to Nate Glasser, who's an internist, pediatrician, and health services research fellow at the University of Chicago. I'm your moderator, Nancy Pandhi, a family physician and researcher at the University of New Mexico. After our talks, I will invite remarks from our discussant, Ann Reynoso, who will be speaking from lived experiences. And then we will be opening up for questions and comments from the audience. For those of you who were at our first opening session, you've already heard these, but just as a reminder, here are our collective agreements for a safe and brave meeting. We want to be sure to practice active judgment, free and empathetic listening, respecting each other's differences and backgrounds, having agreement to disagree, but seeking understanding, remembering that we are here to learn. We want to honor the differences between unsafe and uncomfortable. We want to be curious about intentions, but also recognize that impact is more important. We want to welcome being called in as a gift and remember that this is an invitation to learn. We will be mindful of positionality and power dynamics. We will acknowledge judgments and assumptions, including our own, remembering that we all have biases. We will use inclusive language and avoid using derogatory or stigmatizing language. We will release control, privilege, and notions of being right, and we will accept that things may remain unresolved. We may not feel a sense of closure at the end of this talk. Just as a reminder, please do try to engage. Feel free to be using the chat, using your emoji for reactions. We encourage you to try to keep your camera on during the session so that our speakers and others can have interaction if that feels safe and comfortable. And a reminder that you can disseminate on Twitter, so please feel free to tweet about your reactions externally. And with that, I'm going to turn it over to our first set of speakers. Oh, it looks like there's some challenges happening with sound. Okay.
Is that working? Okay. Hi, everyone. My name is Libby Pfeiffer, and I am a medical anthropologist and a faculty member at Rhode Island College. And today I'm joined by Sara Mendez, who's about to graduate as an undergraduate and just finished up a minor in medical anthropology. Between 2020 and 2021, I conducted a qualitative evaluation of a social risk screening and social care program with a study team at Providence Community Health Centers in Rhode Island. And during this time, Sara was in 3 of my classes, and I was regularly talking about the data that I was collecting in the project. And Sara felt that the information that I was sharing was particularly resonated with her experiences of her parents who are Spanish-speaking immigrants. And she came to me at the end of the 3rd class and said, is there any way for me to be involved in this project? And the data collection was done, but we decided to conduct a secondary analysis of the data together to specifically look at how racism and racialized disadvantage was potentially impacting the social care program. So today we're going to be quickly presenting some of our preliminary findings. And this is Sara's first conference, so we're excited for this opportunity. So to begin, our research was conducted in Providence, which is a multicultural city with a large Latino, Hispanic population and a significant immigrant population. More than a quarter of Providence residents are born outside of the US, and almost half of those individuals are Spanish speakers of various dialects. So our clinics where we were doing our research in was Providence Community Health Centers, PCHC, which serves a diverse urban population. It's the only federally qualified health center that serves the city of Providence, and it does through 6 primary care centers that has an integrated behavioral health component worked in. They also have a homeless clinic, a school-based clinic, and a dental clinic. And PCHC is the largest provider of services to individuals on Medicaid and the uninsured who reside in the city. So PCHC began implementing their social care program in May of 2019, just before the pandemic, screening patients at random once per year. And the screening tool consists of 7 questions that ask about housing instability, food insecurity, exposure to violence, transportation, access to utilities, and then a final question that asks if anyone has needs help with these social needs. Do they want the help? At the end of 2020, PCHC completed almost 40,000 screenings and found that 10% of the people that they screened said that they indicated at least one social need. And of that group, about 36% said that they wanted help with those needs. So the research objective of the larger project was to explore and describe why is it that people who report social risks during social care decline social assistance. And we researched this qualitatively from the perspectives of patients, staff, and social service agency leaders. So to answer this question, we used a remote qualitative research, including telephonic interviews with patients. We did Zoom focus groups with one group of patients who are also part of the clinic's advisory board and community leaders. We did Zoom meetings with clinic staff who work in the social care program, and then we also did a focus group with leaders of social service organizations. So this larger study was just recently published as in the American Journal of Preventive Medicine earlier this month. And to answer the question, found that there are a lot of factors that lead patients to decline, but one of the main findings was stigma and discrimination. And so Sara and I have been going back through that data, exploring in greater depth using a racial equity lens, looking at how racism, or specifically how discrimination enacted towards people because of culture, language, legal or immigration statuses, how that shaped their experiences with social care, and to see if there were ways that maybe social care is inadvertently reproducing various forms of inequalities. So our data revealed kind of direct forms of patient experience with feeling discriminated against, but we also are taking care in the secondary analysis to kind of look up from our data and what are people saying on the ground and connecting it to broader and structural and institutional forms of racism. And so Sara is going to be presenting that now, but we would ask if people who are listening in the audience, if you can take notes of some of the things that we're saying, and then perhaps in a discussion, we can be brainstorming ways that social care programs can become more equitable. So with that, Sara.
Hi, everyone. So during one of the patient focus groups, some of the participants actually stated that they felt overt racism towards them by both the clinic and the social service staff. And that was due to their intertwined racial and ethnic, linguistic, socioeconomic statuses. And one Spanish-speaking woman in particular felt judged by the staff at the front desk based on her race and language. She mentioned that the staff's body language was a big indicator for those feelings of discrimination. And then related to these experiences of being discriminated against because of their immigration status, patients also reported fears, mistrust, and concerns related to deportation and being reported for child neglect. During another focus group interview with the staff, they actually brought up that one of their biggest issues was the language barrier. The staff had to serve as translators while conducting the screening tool questions in order to accommodate for the different cultural backgrounds and education levels of their patient population. They also noted that this had to be done quickly because the clinic they were working at had very tight time constraints. They only had about 15 minutes with each patient. So we observed this as a form of institutional discrimination. And during the focus group, the staff shared that the SDOH questions were hard for the patients to understand due to their language barriers, and people from different Latin American countries use different verbiage and dialects, which leads to confusion when reading a script that was written out for them. And it became the responsibility of the staff to further explain these questions in a way that people could understand. And the staff really expressed the need for these areas to be addressed and the way to make the program more useful and equitable. But they did say that once they brought up these issues, they were basically told that that script that they were given, the verbiage and everything wasn't going to change because it was tied into paperwork. So the social risk screening tool used in the clinic setting has the potential to discriminate against patients whose first language is not English, due to the fact that it disregards problems with translation and dialects. And given the high patient volume, there's just not enough time to ensure that the patients understand the questions that they're being asked. And we noted 3 different forms of structural racism that plays when they interact with the social risk screening tool and the care program. So first was people that were undocumented or uninsured automatically disqualified for social care services. And the staff actually spoke at great length during their focus group about this challenge. And the staff went on to clarify that it was predominantly Black and Brown individuals that were affected by these policies. And they obviously wanted to help all of their patients, but they felt after receiving their screening tool, they felt like they were giving the patients false promises, because once they gave them a call back, they basically had to tell their patients, oh no, I'm sorry, you can't qualify, because the screening tool doesn't ask any questions about legal status or whether or not you're undocumented. And then likewise for patients with criminal record, were also disqualified from social care services. And one of the staff members actually spoke about a patient who he believed was unjustly incarcerated. And now that patient could not qualify for housing and he had to live out of his car. So we became concerned that the requirements to qualify for these social care programs excluded patients that were documented and have a history of incarceration. So this serves as a form of systemic racism, given that Black and Hispanic populations are overrepresented in the Rhode Island prison system. And that data comes from the Rhode Island Department of Corrections and the US Census data. And then patients also spoke about I'm not sure if this is the right slide about the resource availability. Oh, okay. So patients spoke about the resource availability in particular regards to food. So those who come from different cultural backgrounds and those with different special needs diets, such as diabetes, the food that they were given wasn't compatible with what they needed. So for example, in the Hispanic community, in general, a lot of people don't eat canned foods or boxed foods, but also for people with diabetes, for example, they were given, like the food given out was like mac and cheese boxes and peanut butter and jelly, which isn't the healthiest food option, but that's the only thing that they had, basically. So for us, we basically identified this as a form of racism because to cultural preferences and the cultural knowledge of food preparations. And then additionally, on top of that, Black, Indigenous, and Hispanic communities are at greater risk of having diabetes. So if this is the food that's being given out and Black, Hispanic, and indigenous communities are at the highest risk of diabetes, then they're the ones that are being most affected by the food banks, basically. And in terms, the social care programs that provide the food may be exacerbating the health conditions of these people. And then in our, and one of the final focus group interviews, the patients those themes of toxic individualism and assumptions that people are trying to abuse the system. And this led to feelings of shame and guilt, which is felt by those with social needs and simultaneously also facing forms of individual racism. So during one of the patient focus groups, one Black woman stated that the staff knew if patients had visited multiple locations and how often they had stopped by. And she felt like they assumed that they were just trying to beat the system, and they really disregarded the fact that the patients actually needed the resources and they weren't trying to just, you know, get more stuff or trying to beat the system. So in order to avoid being accused or avoid feelings of these shames and guilt, some individuals opted out of utilizing these government services. And to conclude, these data demonstrate that a major reason that patients decline social care is the result of pervasive racism. That intersects of discrimination included language, socioeconomic, immigration, and legal statuses. We have identified through the experiences of staff and patients at CHC that racism is built into the individual experiences, as well as those policies that structure and reproduce the social determinants of health, such as poverty, discrimination, interactions with biomedical and social service agency professionals, and equal access to safe housing, transportation, food security, and quality healthcare in the US.
We just want to say a special thanks to our study participants, PCHC for letting us do the research, and then Siren and with funding from the Robert Wood Johnson Foundation for funding this project. And we would love maybe during the discussion period to think through kind of some of the ways that social care programs can change to be more equitable. Thank you.
Thanks to both of you. And as Arshdeep Kaur is pulling the presentation up, just a reminder, please feel free to put commentary in the chat throughout, and then we'll do discussion at the end.
Right, let me make sure to unmute myself. Right. Okay, hi everyone. My name is Arshdeep Kaur. It's great to be here. So the study that I'm going to talk about today looks at the relationship between experiences of healthcare discrimination and trust in healthcare provider. And so I'm going to try to briefly describe what we did and then really try to focus on the takeaways for social care research. So we've seen so many times in the literature that trust in provider is linked to so many important outcomes, patient satisfaction, use of preventive services, and also that healthcare discrimination is linked to lower trust in provider. And then the other important context for our study is that we're currently in the midst of efforts to increase the integration of social care into our healthcare system. And so we really want to understand these efforts in the context of healthcare discrimination. So in this study, we wanted to understand the levels of healthcare discrimination among adult patients, caregivers of pediatric patients, as well as their trust levels. And we also wanted to understand what are the factors associated with high trust. And so the study was a secondary analysis of a cross-sectional survey. We had adult patients and adult caregivers of pediatric patients, and they came from primary care and emergency department sites across the US. You can see the stars on the map. And the primary outcome that we were looking at was how much they trusted their provider for their child's healthcare provider at that particular study site. And so they rated on a scale of 1 to 10, and 1 through 7 was low and medium trust, and then 8 through 10 was high trust. And then we also asked participants about this list of 7 types of healthcare discrimination, which comes from the Discrimination in Medical Settings tool. And so for each type of discrimination that they had experienced, they got a point on their healthcare discrimination score. And so they had a maximum score of 7. We also asked them if they had been screened for any social risk in a healthcare setting in the past 12 months, as well as if they had been offered assistance. And then the last methods thing that I just wanted to mention is that for the self-identified race variable, unfortunately, because of low sample sizes, the American Indian, Alaska Native, Asian subgroups, and other category unfortunately had to be collapsed into one category, and that was labeled the non-Hispanic multiple and other category. So this table is very large, displays all of our sample characteristics. We had about 1,000 participants, about 40% of them were non-Hispanic white, about 30% were Hispanic, about 20% non-Hispanic Black, and the rest fell into that multiple and other category. And among them, we had some differing levels of trust. And I'm actually just going to zoom into this part of the table on the next slide so we can see it a little bit better. So about 20 to 25% of the non-Hispanic Black, Hispanic, and non-Hispanic multiple and other participants were in that low and medium trust group, compared to only about 15% of the non-Hispanic white group. And these were significant differences. And those differences in trust are just displayed here again in the purple graph on the left side. So you can see that the non-Hispanic Black group was the least likely to report high trust. And then in the orange graph on the right, we can see that about 30% of the non-Hispanic Black participants had experienced any type of healthcare discrimination, compared to about 25% of the non-Hispanic white and the Hispanic participants. And again, these were significant differences. And then in this table, looking at those 7 different types of healthcare discrimination listed here on the left, we can see that the non-Hispanic Black and the multiple and other group consistently reported higher levels of each of these 7 types of discrimination. Interestingly enough, across all of the racial and ethnic categories, the most common form of discrimination in healthcare was that they felt like a doctor or nurse was not listening to what they were saying. And then comparing these 2 groups of low and medium trust versus high trust and looking at their healthcare discrimination scores, it was significantly higher in the low and medium trust group. It was 1.65 out of 7 compared to 0.57 for that high trust group. And that actually also ended up being the relationship that we saw in our regression analysis as well. Again, this table has all the variables we looked at, but I'm just going to zero in on a couple of the really relevant findings. So the major takeaway was that healthcare discrimination score was associated with lower odds of high trust. So with each 1-point increase in discrimination score, meaning an additional type of discrimination that the participant had experienced, their odds of having high trust went down by 26%. And the other interesting thing was that looking at participants who had been screened for social risks or had been offered assistance, or sorry, had been assisted, we found that there wasn't a relationship between that and their level of trust. But we did find this really interesting interaction between having been previously screened and the healthcare discrimination score. So essentially, with each 1-point increase in discrimination score, those who had not been screened had a 26% reduction in their odds of high trust, but that went down to 6% for those who had been screened. So discrimination, regardless of screening, was associated with a reduction in trust, but there was a difference in the magnitude here. So if you had been screened, there was a smaller decrease in the odds of high trust. So the major takeaways here, I'll list 3 of them. So the first is simply that healthcare discrimination is incredibly common. 1 in 4 participants had experienced it. And the more types they experience, the lower their odds of having high trust in their provider or their child's provider. And so the responsibility to build trust really falls on providers and healthcare systems to be trustworthy. And so we're really in need of evidence-based anti-racist solutions, For example, there's a lot of literature showing that patient-provider concordance, racial concordance leads to more satisfaction, better outcomes, better communication. And so hiring and retaining diverse healthcare providers could be one important part of it. But this is definitely an area where it would be great to hear, what folks have seen at their institutions that works, and definitely an area where we're really in need of evidence-based solutions. The second takeaway is that higher trust may be a byproduct of social risk screening through just building rapport and trust with the healthcare team, possibly reducing the impact of prior discrimination. And there are several previous studies of different kinds of social care programs that have found that patients sometimes feel that their providers care more about them or understand their social context better after being in these types of programs. There's also some really interesting qualitative analyses from this study's parent study that found that that patients and caregivers saw value in their provider knowing about their social context and didn't really expect that their provider was going to resolve all of those social needs, but still find it valuable for the provider to know about them. All this being said, though, we're definitely not recommending screening just for the purpose of building trust. There are lots of unanswered questions. We really need to understand what happens if we can't offer adequate assistance with screening. What happens if we don't understand how to implement the screening among diverse populations? If screening itself is discriminatory and actually exacerbates these issues of low trust, which I think ties in well with the previous presentation. So definitely a lot to understand here in this relationship. And then the final takeaway, looking at the relevance to social care programs in general, really is just that these experiences of discrimination were so common. And so social care programs really have a responsibility to avoid traumatizing, or in many cases, re-traumatizing patients who are already coming in with these experiences of discrimination, may already have low trust, and then we need to avoid sort of exacerbating and reproducing those situations within our social care programs. And we also just have a need to include trust as a variable when we're designing, when we're evaluating these interventions, and be open to the idea that maybe our programs actually are exacerbating these issues. We need to be open to understanding, is it possible that our actions, even if well-intentioned, are actually getting in the way of building trust with patients? Of course, the study has limitations. I won't go into all of them here, but just want to highlight that it was cross-sectional. And so we can't say that discrimination causes low trust. There's also a possibility of social desirability bias, although we do think that this might actually be leading to underreporting of participants' healthcare discrimination experiences. So thank you so much for your time. And of course, thank you to all of the patients and caregivers for sharing their experiences, and the whole study team. And I'd love to answer questions at the end and talk with our fellow participants. And my email address is here if you'd like to talk more. As I said earlier, I'd love to hear your interpretations of the data and what your kind of on the ground experience shows when it comes to this relationship between trust and discrimination in social care programs. And thank you. Feel free to reach out.
And thank you. So now we will listen to Nate Glasser.
Sorry, can everyone see my slides? Sorry. Okay, great. I see some heads nodding. Well, thank you so much. I just want to say that I have no conflicts of interest, and I just want to acknowledge the role of my funders. So food insecurity is not only a prevalent modifiable risk factor for adverse health outcomes and health disparities, but it is also uniquely stigmatized, making efforts to address it particularly challenging. Defined as limited or uncertain access to nutritious, healthy food, upwards of 10% of US households are classified as food insecure. The rate of food insecurity among African American and Hispanic households with children is nearly twice that what it is for non-Hispanic white households with children. Food insecurity has been tied to a range of adverse health effects, including developmental problems, ED utilization, hospitalization, and poor overall health in children, and poorer mental health, impaired management of diet-sensitive diseases like high blood pressure and diabetes, as well as poor overall health and impaired self-care in adults. A large body of scholarship links food insecurity to various types of discrimination. A framework from education and human development researchers at the University of Delaware, Valerie Earnshaw and Allison Carpin, and this figure on the slide is adapted from their framework, articulates sort of the complex web of mechanisms by which various forms of stigma and discrimination, from the structural to the individual level, can precipitate and exacerbate food insecurity. Their framework outlines how everything from unequal transportation access to food costs to targeted marketing to cultures around eating and internalized stigma can contribute to food insecurity and low diet quality. Several additional studies by Burke and colleagues, Chisholm and Vojanikon, find that self-reported experiences of discrimination and perceived stigma are associated with the levels of food insecurity with an apparent dose response, such that higher levels of discrimination are linked to higher amounts of food insecurity. For me as a researcher, I often find I'm especially interested in exploring mechanistically how micro-interactional and social dimensions of behavior, particularly health behaviors, develop, especially in relation to outside forces. For instance, a lot of my research outside of this project has to do with masculinity, how cultural narratives and schemas around gender appear to shape behavior that can have implications for health. And in thinking about connections between food insecurity and discrimination, my team and I hypothesized that self-efficacy might function as one such interrelational mechanism that links interpersonal experiences of discrimination with behavioral outcomes related to management of food insecurity. Initially described by psychologist Albert Bandura, self-efficacy refers to beliefs in one's capabilities to organize and execute a course of action required to produce given attainments. Importantly, Bandura and others outline four main sources of people's self-efficacy: mastery experiences, having effectively performed or completed a particular task might support one's belief in their ability to do it again. Vicarious experiences, how seeing someone who looks like you successfully completing a task might buttress your belief that you could do it again. Social verbal persuasion, how somebody who is encouraged or told that they could do something might be confident in their ability to do it again. And emotional states like degrees of stress and anxiety. Self-efficacy has previously been associated with a range of health behaviors: medication adherence, cigarette smoking, physical activity, adherence with prescribed dietary patterns, glycemic and metabolic control in patients with insulin-dependent diabetes, and in one trial with antiretroviral therapy adherence in people with HIV, even controlling for other cognitive, personal, and environmental factors like depression and physical limitations. And so we wonder if self-efficacy may be one piece in the chain linking experiences of discrimination with worse outcomes related to food insecurity. I should, of course, note that our thinking of self-efficacy and its relation to behavior in the context of food insecurity is not an attempt to blame anyone for their experiences of discrimination, but rather to take a full accounting of the myriad ways and mechanisms that discrimination at either a structural or interpersonal level might lead to various, though invariably negative outcomes, and also to suggest the full range of interventions we might need to enact in order to undo discrimination's deleterious effects. And here's a visual depiction of how we are hypothesizing self-efficacy might, at least in part, connect people's interpersonal experiences of discrimination with health behaviors related to food insecurity. So to begin our evaluation of, and this is just a preliminary sort of step of connections between experiences of discrimination and self-efficacy before looking at possible downstream implications for food insecurity issues, we do two things in this current preliminary analysis. We first look at how self-reported experiences of discrimination vary between participants reporting different levels of food insecurity, and next at associations between experiences of discrimination and self-efficacy. In future studies, we hope to expand our analysis to include downstream behaviors related to food insecurity, especially now that this data is becoming available as part of the trial from which we are extracting the data used in this analysis. This trial is a double-blind randomized controlled trial, the Community RX Hunger Trial, which tests the effect of a low-intensity social care intervention on self-efficacy, stigma, food insecurity, and related outcomes among people and caregivers of children under 18 who are hospitalized at a 155-bed children's hospital in the south side of Chicago. This hospital sees approximately 5,300 annual admissions and serves a catchment area in which 53% of families live below the federal poverty level. At the time that this analysis was performed, the trial had enrolled 244 parents and other caregivers between November 2020 and April 2022, just to the control arm of the trial, and we are using data only from those who were enrolled to that control arm. The exposure variables we used in our analysis included community-based discrimination measured at baseline using the Experiences of Discrimination scale, and hospital-based discrimination measured at 7 days following discharge using the Discrimination in Medical Settings scale, I think very similar to the one Arshdeep used in her study. Our outcomes of interest were general self-efficacy and self-efficacy for finding community resources. Both of those were scored at using a Likert scale. Food insecurity status was categorized into 3 groups: secure, marginal, and insecure, based on people's responses to an 18-item USDA household food security survey that was also administered at baseline. The covariates that we included in our ultimate samples were gender, race, ethnicity, income, and relationship status defined as partnered. So if you were married or reported any other significant partner, versus unpartnered, which was people who reported they were single. We then compared average frequencies and percentage of people reporting experiences of community and hospital-based discrimination between participants who were classified as secure, marginal, or insecure in terms of their food security status using chi-square tests. And then we modeled associations between self-efficacy, both in general and for finding resources with each type, community and hospital-based, of discrimination using multivariate regression analysis adjusting for covariates. We had 2 hypotheses. First, that people with higher levels of food insecurity would report more frequent experiences of community and hospital-based discrimination, and that more people with higher levels of food insecurity would report experiences of discrimination. We also hypothesized that more frequent experiences of discrimination would be associated with lower self-efficacy, both in general and for finding resources. I included an appendix with tables describing our full demographic characteristics broken down by food insecurity status. Again, secure, marginal, and insecure, but for ease of presentation, I just pulled out some highlights below. The average age in our sample was 35. 20% of these people were college graduates, 41% had some college or technical school, 28% were high school graduates, 11% had less than high school education. 94% of the participants identified as female, the rest is male. 80% of the sample identified as Black or African American. 55% were employed and 53% described themselves as unemployed. 53% of the people of the participants reported that they were partnered, again, either married or in a significant relationship. 47 described themselves as single or unpartnered. There was no statistically significant difference between any of these demographic characteristics in any of the groups. There were significant differences between the groups in insurance status. So higher rates of Medicare and Medicaid enrollment were seen in people who were food insecure than people who were food secure. But interestingly, highest in those who had marginal food security. Annual income was less than $50,000 in more families who were food insecure than those who were marginally food insecure, and then those who were food secure. Examining experiences of discrimination by food security status to evaluate hypothesis 1, we found statistically significant differences in the average reported frequency of hospital-based and community-based experiences of discrimination between the 3 groups. It was seen more in people who were reported being food insecure than people who were food secure. We also found that a higher percentage of people who were food insecure and marginally food insecure reported at least some experience of hospital-based and community-based discrimination, though this was only significant for the hospital-based discrimination. In terms of the other main outcome of the study, we find that as hypothesized, experiences of community-based and hospital-based discrimination are both significantly negatively associated with self-efficacy for finding resources, with a 1 unit increase in experiences of community-based discrimination associated with a 0.03 decrease in self-efficacy for finding resources, and a 1 unit increase in experiences of hospital-based discrimination corresponding to a 0.06 decrease in self-efficacy for finding resources. Community and hospital-based discrimination were also negatively associated with general self-efficacy, but these findings were non-significant. Ultimately, and in conclusion, we find consistent with prior research that experiences of community-based discrimination were more common, and when they occurred, more frequent in people with increasing levels of food insecurity, and that people who experienced hospital-based discrimination experienced higher frequency of discrimination the more food insecure they were. We also found that experiences of discrimination appeared to be associated with decreased self-efficacy in general, though this finding was non-significant, and for finding resources. And again, this was a significant finding. In terms of limitations, I should also say that all these associations appeared to be independent of people's race, ethnicity, income, and relationship status. In terms of limitations of the study, which of course there were many, while the temporal dimension of the survey design, where experiences of hospital discrimination and self-efficacy are queried 1 week following discharge, suggests that there's maybe a possible directionality to the relationship. There's no way to establish any kind of causal link. The models also don't control for baseline reports of discrimination, which might have helped isolate the impact of any new discrimination during the hospitalization. And then I think most importantly, in terms of the next steps, now that we've provided some evidence for this link between experiences of discrimination and self-efficacy, the goal would be to sort of expand our analysis to involve possible associations with downstream behaviors that are related to food insecurity management, such as utilization of community resources, enrollment in SNAP and WIC, follow up with medical recommendations. And then beyond that, should these associations prove significant, our focus on self-efficacy in this study as a link on the causal pathway suggests possible future interventions or directions for future interventions, such as those that would increase and raise individual self-awareness. And then just a brief word of thank you to various collaborators and sponsors.
Thank you so much. So now I will invite remarks from our discussant, Ann Reynoso.
Hi, everybody. I'm Ann Reynoso, and very briefly, I am a person of lived experience. I do have a rare illness that I am dealing with in this late in my age. So I've seen both spectrums of healthcare. I also have a master's in sociology. So this particular subject really interested me. I'm very interested in discrimination and racial and inequalities of social care. Going and listening to all of your research and your implications on what you found is very interesting. But the keynote that I noticed, and I've been taking notes here if you don't mind, but the keynote that I've listened to mainly were the mistrust that people felt in healthcare or in finding community help or resources. And I do find that is to be true. And there are so many things that go with that. And I've written down so much, and I know that I don't have a lot of time to go over everything, but I just want to briefly say that I want to cover the fact that I've noticed with all of your research and your statistics and all that, I noticed that mainly females are the ones that are really have been noticed in a lot of these statistics, and makes me wonder why. And I wonder, where are the men? Are they not being asked anything, or maybe they're the ones that are not being forward about finding resources? Maybe women most of the women are single, which I noticed in the statistics you've had that they are. And of course, most of them are minorities, and that I mean, I am Hispanic, so that being Hispanic or the Black community, and it's just surprising to me that a lot of men are not included in this. It's not by anybody's fault. It's just probably choice of their own. I do want to say something about possibly why men are not involved. And I think a lot of that is, and this is from experience, men usually, and especially in the Hispanic community, and from my experience, is that they usually work in a craft. And when they work in a craft, some of them are offered, depending on the size of their company, healthcare, and it is very, very expensive. And so some of them are offered healthcare and don't have to pay for themselves, but they do have to pay for their families. So that leaves the wives and the children without healthcare. And so these wives and children end up having to go to community-based healthcare. And a lot of time, and I know from experience too, that community-based healthcare, they're very overwhelmed and inundated with a lot of patients, especially those of low, low income. And sometimes I feel like maybe they're just tired and in a hurry to get through each patient. And it's like a manufacturer. It's like, okay, let's go down the line, let's get this patient out and give them to triage, and then move them into a room, and so on and so forth. And it just keeps going that way. And I think it leaves people to feel helpless. And it leaves people to feel like they are not being heard or seen. And I think that is where a lot of the mistrust comes in. I want to give a very brief example of my experience. I went to a doctor before I found this great doctor of mine. And I went to a doctor and I told them my situation, my symptoms. And the first thing he did was look at me and say, well, you're overweight. If you would lose weight, you'd probably be healthy. And that was the very first day in my life that I had to learn how to advocate for myself, because no one was going to do it for me. So I just want to know, through all of your research and everything, and all the findings that you had, what and where, if it's through the federal government, or how are we going to do this through the community, through other organizations, nonprofit organizations, how and where are you going to help these people to feel like they are being heard and seen? And what are your recommendations, really? I know what your findings are, but what would be your total recommendations, especially those of you who are in the position to understand the medical side of it? Yeah, doctors and nurses, you understand that side of it. I understand my side of it, but coming through your side, what do you feel that would be possible for us to need and get us to be able to build that trust and find that self-efficacy that we're not afraid to look for?
Thank you, Ann. I think this is a great way to start our discussion here. So appreciate your comments. And I would invite the group to put in the chat your recommendations or answers. And if anyone wants to raise hand and jump in directly to respond to that, any of our speakers or others. So let's get a dialogue going here. Hearing what we've heard, what can we do directly? So I am seeing a response to the gender question in the chat here, where Stacy Lindau comments that it might be that, let's see, Stacy, do you want to verbalize that? That might be easier as well.
I can also kind of paraphrase her comment, which is that most of this data was collected during pieces of the COVID pandemic when only one of the caregivers of the child was permitted at the bedside during the hospitalization. And then she was citing existing data that mothers dropped out of the workforce at higher rates than fathers during the COVID pandemic. So the kind of the two data points together might explain some of the discrepancy.
Great. And so there was oh, go ahead. Yeah.
Oh, I was just going to say, in response to Ann's earlier question about recommendations, I thought that our first presentation offered some really good concrete ways of ways that social care programs are kind of enacting this kind of discrimination. And I felt like more community integration into actually designing these sort of programs and interventions could be sort of one way to intervene. I think that a lot of the times these programs are sort of designed top down. And so I think maybe the field may be moving more towards integration of community member input and leadership into kind of being there from the get-go and in the evaluation process as well. So I think there's room for, you know, this whole spectrum of community-based participatory research, but also sort of integration throughout the process when we're creating these sort of social interventions.
Thank you. Other thoughts? I see another question in the chat here. Has anyone uncovered any differences in trust based on how systems actually respond to social needs?
I'm not aware of any studies that have looked at that, but it seems like that's a great thing to potentially track as we are following the implementation of these interventions.
Other questions, comments?
I'd like to also point out too, I live in Texas, and there's just a lot of situations that we run into here when it comes to social care and health needs and community-based help there are a lot of community-based help here in each county that we have here in Texas, but funds are very scarce. And because funds are very scarce, it's really hard for nonprofit organizations and any other community health centers to help people who are, and my concern is really the children, is to help these children who do need to eat. And I like to get involved with the Head Start program, and I've noticed that a lot of those facilities that help low-income moms and families with daycare and early schooling, which is why it's called Head Start, don't have a lot of funds. And I think that's a big problem, is not having a lot of funds to help a lot of the communities when it comes to food scarcity or health programs or building a trust, because they're afraid to ask for something they know they're going to be turned down for. It's embarrassing to have to ask for help in the first place and then being turned down, because for many reasons, whether you're an immigrant and you don't qualify, to maybe you're not maybe $100 away from poverty level income. Those are hard to deal with for a lot of patients and families. So I think that we just need, and I don't know where to start with that. Maybe somebody has an answer with that might be able to tell us, where do we start with how to go about getting more funds?
Thank you. I see a hand raised. Tia Francis. No, can't hear you. No, sorry. I don't know about others, but I'm unable to hear. No, unfortunately, can't hear. Okay.
There. If somebody has a question, I'll certainly stop, but just to sort of speculate a little bit about sort of the findings of all presentations together. I think my overall takeaway is that interactions matter deeply, and the way that we kind of communicate, or clinicians communicate with patients who are seeking services, matters deeply, and it, I think, speaks to dimensions of kind of clinician-patient relationships, and that we need to give a lot of care to the way that we interact with patients to ensure we're providing an encouraging environment that's a partnership, that's respectful, that's reciprocal. And I think that's sort of my primary takeaway from the three presentations.